Okay, so we're going to continue with preterm labor, a little bit more about preterm labor. So yeah, they might be complaining about this low backache pressure stuff. We just have to figure out, well, what is it? Is it preterm labor? Is it this false labor or Braxton Hicks contractions? Again, it's about cervical changes. There's a test called fetal fibronectin, FFN. Fetal fibronectin is a protein, I think, that a cervix that's losing its integrity. Remember when we talked about inducing labor, ripening the cervix, how the things that we do to disrupt that integrity, the stripping, the pulling, the tugging, the whatever I talked about yesterday. This we try to do artificially to induce labor or to ripen the cervix. Well, if the cervix is ripening on its own when we don't want it to, it's losing its integrity, that bond with the amniotic sac and all of this, and it gives off this protein, this fetal fibronectin. So, that might be the change. That might be the cervical change that is not as obvious as dilation and effacement and all those changes. So, we watch somebody come in, we watch, yeah, she's having some contractions. She's not having any bleeding. She's not having anything of that, but she is contracting. Giving her IV fluids and rest doesn't seem to have helped. She's 1 centimeter dilated, but she was that one in the office last week. They'll do a fetal fibronectin test and send that to the lab. And we'll see, is that membrane losing its integrity or not? All right. And really all that does is say that if it's positive, how do I put this? If it's positive, it means she will most likely deliver within 2 weeks. If it's negative, it doesn't really mean anything. So it's not, it gives us another piece of the puzzle, but we can't say for sure that she's not going to deliver. We just know when it's positive that she will deliver, or she'll dilate anyways. All right, so it's it's just a piece of the puzzle. We're going to do some other things. We can measure cervical length with ultrasound. There's different medications we can give to stop contractions. And if we can, we will, naturally. Obviously, we're going to get them resting, hydrate them, identify and treat any infection. Let's try to figure out what is causing the problem in the first place, and get to the source of it. So there's different medications we can give, called tocolytics, as I know I've mentioned that word before. Tocolytics are medications that suppress uterine contractions. All right? What we're trying to do is stop the contractions, therefore stop the uterine change, the cervical changes, blah, blah, blah. So there's a couple of different kinds, beta-adrenergic ones, calcium channel blockers, and prostaglandin synthesis inhibitors. Well, of course, every drug has side effects, some of which are rather serious. So we're fixing one problem and creating another one. Pulmonary edema, it seems to be a side effect from all of these medications, actually. So we just have to be very careful. We can take an otherwise healthy young woman and create some other problems in trying to. We can't be 100% focused just on her belly, right? We have to take the whole patient into mind. So our beta-adrenergic agonists, ritidrine, which I don't see very often, but terbutaline. Terbutaline is the one I see most frequently, and ironically, it is not FDA approved for tocolytic, but that's the one we use.
Do they know?
Yeah, I'm sure they do. Yeah, I'm sure they do. I don't know why it's not FDA approved, but it's not. Beta-adrenergic agonist, that's a cardiac drug though, no?
Yeah.
Blood pressure?
Yep.
Yeah. So just think about that for a minute, right? So yeah, we're stopping the contraction, but in the meantime, she's like, because her blood pressure's dropping. If she doesn't have a blood pressure issue, she's gonna have a hypotension issue. So we just have to be very careful about blood pressure and pulse.
Do you increase fluids with that?
We gotta watch out with the pulmonary edema. So yeah, yeah, there's a balance there. So it's no joke kind of medication. But if we find that we can stop it, we can give her PO terbutaline, and she can go home in stable condition taking that. Another beta adrenergic agonist is magnesium sulfate. That smooth muscle relaxer we talked about with the PIH, or the pregnancy-induced hypertension, can be used to prevent or to stop or slow down or weaken uterine contractions, like I said. And we have used this medication to do just that. But they have their side effects, and it's one of those medications that we just have to make sure we're keeping tightly controlled. All right. This medication they can't be sent home on either. This is an IV medication requiring continuous monitoring, and they're staying in the hospital when they're on this med by all means. Because of the nature of this med, flushing, feeling warm, headache, nausea, dizziness, lethargy. I mean, all of these things are perfectly reasonable side effects, which don't make them feel any better, but that's what's going on with them. Fetal side effects, as I mentioned before with the PIH, hypotonia and lethargy for 1 to 2 days afterwards. Respiratory depression, really, especially with the magnesium sulfate. And then you have your calcium channel blockers. Calcium channel blockers, Procardia being the one I have seen. I'm seeing it actually more and more, maybe because I don't know if I didn't say there if it's FDA approved or not, huh? Well, I don't know. The thing about Procardia, it's one of those drugs that is easily administered, and they can be sent home on this drug as well. But it causes vasodilation, hypotension, tachycardia, flushing. They feel pretty lousy on that drug too, because they don't need it for their blood pressure, but we're giving it to them anyways, So they can feel pretty lousy, but they're not contracting, so. Some prostaglandin synthesis inhibitors, Indocin. We don't see this very often at all. This is kind of almost a last-ditch effort one, because it does have potential serious side effects. All right, we will have tried everything else and nothing else will work. Then we'll try this. Okay. There are some women who have a history of preterm labor or preterm delivery with their first baby. Remember, was it last week? It must have just been last week. When I talked about the theories of what causes labor, one of them was progesterone withdrawal theory. So we're going on, if that's really what caused the preterm labor in these other patients, we're going to give them progesterone. Every week we're going to give them a shot of progesterone, which is this Makena. So our hope is that if they continue with a healthy dose of progesterone, from 16 to 37 weeks pregnant, that they won't go into preterm labor. So for the people who went into preterm labor because they had low progesterone, this works. For the ones who went into preterm labor for a different reason, it's not going to work. But it does prevent some.
If the woman has regular progesterone and they're given this supplement,
I don't
would
think
it cause any other
like
complications?
progesterone overload. I don't think so. I wonder about the side effects of progesterone supplementation, if there is any.
Baby be hairy, you mean?
I'll have to follow up. That'll be we have to wait till puberty for the whole bit. Oh, that's testosterone, isn't it? Progesterone can do it too, right?
Procardia isn't FDA approved, it's still in clinical trials.
Thank you.
for that.
Clinical trials, we've been using it for a good long time. But anyways, I guess we're part of the clinical trial. Anyway, so progesterone, I've never heard of a problem with like giving too much. Like If they don't need it, but we're giving it to them anyways, I've never heard of a problem. But that might be something to look into so that when I have a very smart student ask the same question next semester, I'll have an answer.
Because I just thought progesterone and estrogen were kind of counterbalanced.
Mhm.
So then, I don't know, if you give too much progesterone, would
I don't know. I don't know the answer, but I hope to before the next person asks me that question. I don't know, but that's something definitely to think about, but I don't think so. In the meantime, we're doing corticosteroids, all right? We're gonna give a betamethasone is the drug that I'm thinking of, a glucocorticoid. The brand name that you'll see often is called Celestone. Celestone is, it's a steroid, and there's two reasons to give it. We might give it IM, and then 24 hours later give another dose. This is supposed to hasten fetal lung maturity, all right, to bring them a little bit closer to being able to breathe on their own. In the event that what we're doing doesn't work, and they end up delivering earlier than we want, all right? But we have to worry about side effects, pulmonary edema being one of them, okay? We've been giving glucocorticoids one dose, and it's supposed to help with necrotizing enterocolitis and some brain hemorrhage stuff. So even if they don't get the 2 doses, they found that giving mom even 1 dose lessens the chance of some pretty serious premature infant complications. So yeah, you'll see it under a couple of different names: betamethasone, dexamethasone, Celestone. Oh yeah, here it is: intraventricular hemorrhage and necrotizing enterocolitis. So even just 1 dose can help with that. All right, you got your premature rupture of membranes. It's when water breaks and labor doesn't start right away. All right, or maybe it's just a couple hours in between, but it's premature rupture of membranes. Labor has not yet started. And then your preterm premature rupture of membranes is, thankfully labor hasn't started, but we really didn't want a water breaking either. All right, before the 37th week, between 20 and 37 weeks. Well, they're certainly at risk for infection, both mom and baby. Chorioamnionitis is the infection we're most concerned about. And the clock starts ticking in at the 24-hour mark, we get pretty concerned about that. And we'll figure out, like I said a couple weeks ago, we'll figure out is this indeed rupture of membranes. A bunch of different tests we can do to find out if that's the case. All right. I have seen that some, yes, that's one of them. Take a big sniff, the sniff test, we'll call it.
Still in clinical trials.
Still in clinical trials.
FDA approved.
If I was a new nurse and me as her preceptor said, just take a big whiff, take a whiff of it and it'll tell you, I'd be like, you want me to do what? You want me to smell this bodily fluid?
smell and scent in your pants.
Yeah, I'm not sure that's reasonable. Anyways, that's completely unreasonable. So we'll go through the proper methods of determining if what's leaking out of this woman is indeed amniotic fluid. So then we will do what? We still don't want her to go into labor, so we're going to do a couple of different things. We're going to try to hold off on labor. We're going to give her antibiotics. Probably do the betamethasone. What'd you say?
Fetal cardiac.
Oh, definitely. Oh, thank you. Yes, absolutely. In fact, if it was truly a big gush of fluid, I'd be more worried about the preterm ones because they're smaller and that cord can come to. They're not necessarily already engaged in the pelvis, so we have a breaking of water, and that's when those are most of the prolapse cores that I've had have been on preterm PPROMs. We call them PPROMs.
Have you ever actually seen
I've had a patient come into the hospital by ambulance, I don't know how many, 27 weeks pregnant, broken water with a cord hanging out of her vagina. Yeah. So, it was pretty obvious what the problem was. That was the only test we had to do, is see that that was there. So that's trouble. But some of these women, actually, it might have been a slow leak or a high leak, and they actually sealed themselves, it seals it off, and they go on to, with close monitoring for infection, they go on to stay pregnant for quite a while. They might even be discharged home. Okay? We're gonna do everything we can to keep both mom and baby healthy for as long as possible with these patients. Pretty much that. And it includes this whole sterile exam and, you know, keeping the risk for infection down in terms of frequent exams and all sorts of things. But yeah, we're gonna be looking for all those signs of infection. Keeping tabs on baby, and just hopefully, you know, getting her to a more reasonable gestational age before delivery. That's I pretty much said all this, didn't I? All right. Yeah, they might be able to go home. I think that's pretty cool.
No bounce.
Oh gosh, no. Oh, that's it? Oh. Huh.